Good afternoon, everyone. It's time for our last D2ME meeting before we go on our summer break. Our speaker today is Meredith Molnar. She works at our Spring Valley office for Lexington Medical Center, and she's going to be talking to us today about diabetes and hypertension. As you know, as you just heard, I am recording this. So hopefully when this is over, I will be able to get it up and post it maybe on Facebook or the YouTube channel for LMC within the next few days. All right, and with that, I will turn it over to Meredith.
Oh, hi, everybody. I just wanted to show my face and then I'm going to turn my video off so I can do the screen. And I haven't done a Zoom meeting with me sharing the screen. So if there's a little glitch, just give me a second and I'll figure it out, okay? Okay, so we're going to talk about diabetes and hypertension, okay? So my name is Meredith. Like she said, I'm a nurse practitioner over at Spring Valley Family Practice over in the Northeast. It's right by that new Lexington Medical Center building off of Clemson and Longtown. We're around the corner from that. I've been there since 2017, and since 2017, I've gotten 2 certifications in diabetes. So I have a board certification in advanced diabetes management and also a certification in diabetes and care education specialist. And before that, I was a nurse and I worked in intensive care and various positions before I moved here from Cleveland. So let's get started. Okay. So how I'm going to do it is we're basically going to go over what is blood pressure, what is hypertension, then we just, have a review of like what is diabetes, and then I just kind of want to bring it all together to kind of talk about complications of both and how they kind of contribute to each other's complications and why we are so big on trying to control our blood pressure and our blood sugar and cholesterol and all that stuff, okay? So first we got to say, like, what is blood pressure? Okay, so we know we get the numbers every time we're at the doctor's office. They tell us our blood pressure is 130/80, 120/80. Okay, but what does that actually mean? Okay, the definition of blood pressure is the pressure of blood pushing against the walls of your arteries. Okay, the arteries carry the oxygenated blood from your heart to the rest of the body. Okay, our blood pressure normally fluctuates throughout the day, but if it remains elevated for long periods of time, it can actually cause damage to our body. So blood pressure equals the cardiac output, and I'm going to try not to be too out there with medical terms, okay? So the cardiac output is basically how much blood is ejected from our heart every minute by the beats and by our, how fast our heart rate is going, and also called stroke volume, okay? So the blood pressure is the cardiac output plus the total peripheral resistance. So how much pressure has to be exerted to get the blood flow out of our heart, okay? So our blood pressure is regulated by 3 main things: the sympathetic nervous system, the renin-angiotensin-aldosterone system, which is kind of a tongue twister, and our plasma volume, which is largely mediated by the kidneys. And guys, if you have any questions, by all means, just chime in, okay? All right, so with the regulation of our blood pressure with the sympathetic nervous system, okay, that promotes what's called heart contractility, which is basically how well the heart is squeezing and the heart rate. It maintains our cardiac output, so how much volume is squeezed out of our heart every minute. And it maintains adequate peripheral resistance, so make sure we're not having too low of a blood pressure, okay? But issues when we have high blood pressure, which is hypertension, we have an overactivity of that sympathetic nervous system, which causes an increased production of epinephrine and norepinephrine. That's kind of like your fight or flight response. And then we have increased receptor reactivity involving those fight or flight sort of enzymes, okay? This causes some structural changes in the blood vessels. Our salt, so we always talk about sodium when we're talking about blood pressure and trying to decrease our blood pressure naturally through diet. We talk a lot about salt. So we can retain salt, which in turn causes us to retain water, okay? And this increased sympathetic response also increases the renin and angiotensin levels in our body, okay? It's a lot. Okay, so with the renin angiotensin aldosterone system, that's basically trying to maintain homeostasis, which that's like the balance in our body, okay? So that's trying to maintain the blood pressure and tissue perfusion, which is the circulation throughout our body, okay? So there's two main hormones, which is angiotensin, which is the chemical in the body that narrows our blood vessels, and aldosterone, which regulates our salt and water levels in the body, okay? So with dysfunction in the renin angiotensin aldosterone system, we will have an increase in peripheral resistance and an increased sodium retention, which would ultimately increase our blood pressure. And then with our plasma volume, so that's our blood and water volume, the kidneys are responsible for a lot of the regulation of our salt and water retention. So with dysfunction of that system, we have more salt and water retention, which in turn increases our blood pressure. Okay, so when we have blood pressure, we get the two numbers, okay? We have the top number and the bottom number. The top number is called the systolic blood pressure. So systole is when our heart squeezes. That's the pressure in the arteries when the heart squeezes. The normal is less than 120. That's our goal. The bottom number is called the diastolic blood pressure. And that is the pressure when our heart is relaxing, or the filling phase of our heart. Normal is less than 80. These are just kind of examples of from the American College of Cardiology, just where we're kind of looking at ranges of blood pressure. If you're in the office, we could say, oh, it's normal, it's elevated, or do you have high blood pressure? So usually when we're monitoring your blood pressure and we're worried about it being high, usually we'll have your blood pressure taken on 2 separate days to confirm if your blood pressure is in fact high. This is just another sort of chart that's showing the normal blood pressures when we're kind of worried about it or getting towards the hypertensive stages, and then when we have high blood pressure. Okay, so when we have blood pressure that's above 140/90 or 130/80, depending on the provider's guidelines, that would be considered high blood pressure or hypertension. I just wanted to kind of go over some of the statistics, okay? So about 500,000 deaths in the US included high blood pressure as a primary or contributing cause. About 45% of adults in the United States do have hypertension or are taking medication for hypertension. 1 out of every 4 people, so there's only about 25%, have their blood pressure under good control, which would be considered less than 140/90 or less than 130/80, depending on the guidelines we're following. And that contributes to a lot of costs, which would be $131 billion that was spent per year from 2003 to 2014. Those are the latest statistics that I seem to have been able to find per the CDC. Who gets it? So it seems pretty even between men and women, but men are a little bit more common to have high blood pressure. It is more common in non-Hispanic African Americans and Caucasian adults. And then we have 39 and 36% for non-Hispanic Asians and Hispanic adults. And then this is just another graph showing the prevalence of hypertension. And if you see us down there by the arrow, we're in the darkest color. So that's 32 to 38.6% of people ages 20 and older that are have high blood pressure, which is a lot. And then we go back to in South Carolina, 1 in 3. So that's almost like 30%. That would be the average. And a lot of people don't know they have it because blood pressure is a silent killer because most people don't feel any different. Usually we're like, oh, we're worried about chest pain, nosebleeds, but a lot of people don't have that, but still have high blood pressure. That's why we want regular medical appointments so we can monitor those things and catch it before it becomes a big problem, okay? These are the risk factors for developing high blood pressure, okay? There's modifiable, which is things that we could potentially change, and non-modifiable, okay? So non-modifiable would be your gender. You can't really change your DNA. You can't change your age. You can't change your genetics or your ethnicity, okay? What we can change is if we're active or not active, medications that we take that could be contributing to an elevation in blood pressure, some drug use, smoking, if we have a lot of stress, if we're drinking a lot of alcohol, and if we're overweight. This is just another little statistics slide that shows hypertension and high blood pressure accounted for more cardiovascular disease-related deaths than any other modifiable cardiovascular disease risk factor. And that was second only to smoking as a preventable cause of death for any reason. And 50% of the deaths from coronary heart disease and stroke, that would be like a heart attack or stroke, were among individuals that had hypertension. And just as I mentioned, the complications of uncontrolled hypertension do increase your risk of having a stroke, which is a CVA, a heart attack, which is a myocardial infarction, and kidney failure, which is renal failure. Okay. Whew. So we're going to switch gears to diabetes, and then I'm going to try to bring it all back together. Okay, so diabetes, there's 3 main types: type 1, type 2, and gestational diabetes. Type 1 diabetics, we're used to that being the juvenile diabetics or in younger individuals, but that is basically an autoimmune condition, whereas there's complete destruction of the pancreatic beta cells or a complete absence of insulin. And that accounts for 5 to 10% of individuals with any sort of diabetes. The most common one, which is what we're kind of talking about today, would be the type 2 diabetes. That's where there's an impairment in the insulin production or there is an insulin resistance, which accounts for 90 to 95% of people with diabetes. And then we have gestational diabetes, which is diabetes that's diagnosed during pregnancy and usually disappears after pregnancy. I will have to say that there is a potential 50% risk of a person with gestational diabetes developing it later in life outside of pregnancy. The definition of type 2 diabetes is the impaired insulin secretion, insulin resistance, or abnormally elevated glucose production by the liver. So when we're trying to diagnose with somebody with diabetes, there's a couple parameters that we're using. The fasting glucose, which is the glucose that we check on your blood if you're doing fasting labs. We like to have you fasting at least 8 hours before we check it. And if that value is about 126 or higher, that kind of gives us a little clue like, hey, we might need to be testing for the potential for diabetes. Otherwise, there's a random glucose greater than 200. So if we are in the office or something and we randomly check your blood sugar and it's greater than 200, that gives us kind of a clue we need to be investigating more. Or the hemoglobin A1C, which would be greater or equal to 6.5%. So the A1C is your average blood sugar over the previous 3 months. And we only check that about every 3 months because that's about how long it takes for your blood cells in your body to turn over. And that kind of sits on those cells. So it doesn't matter if you ate a piece of cake or haven't been eating too well in the last 2 days. That'll kind of give us an indication over the previous 3 months. With type 2 diabetes, this develops over 5 to 10 years. So with type 1 diabetics, most of those will present feeling like they're sick, maybe have a virus or something like that. But a lot of times with type 2 diabetes, there's just general symptoms that you may not attribute to your blood sugar being high. Common symptoms might be what's called polyuria, which is where you feel like you're urinating a lot. Excessive thirst, so feel like you can't get enough water, very hungry or craving foods. If your blood sugar is really high, you might actually get weight loss, be fatigued, and have some recurrent infections like urinary tract infections, or with females, some vaginal yeast infections, or if we're having a wound, we'll have more trouble with healing. But a lot of people might actually be asymptomatic, which means they don't have any symptoms of this. We might just randomly find it on labs. Other symptoms, which I find that a decent amount of men will actually find if they're complaining of some sexual dysfunction. That gives us kind of a clue, hey, we should check your blood sugar as well. But most people will be kind of asymptomatic that I seem to see. Risk factors for type 2 diabetes. Again, some of them are not modifiable, such as your ethnicity, your family history, your age, gender. Other risk factors that would clue us in would be gestational diabetes, so that was during pregnancy. PCOS is polycystic ovarian syndrome, so that is an endocrine disorder that's pretty common. And that is associated with what's called a metabolic syndrome. So we're looking for a risk factor for developing diabetes or high cholesterol with what's called PCOS. Modifiable risk factors would be if you are sedentary. So if you're not very active, if you are overweight, if you do have high blood pressure. So we're going back to high blood pressure as a risk factor for diabetes, and also elevated cholesterol. Statistics for type 2 diabetes. So about 34 million people in the US have diabetes. However, 1 in 5 don't actually know that they have it. So that's kind of scary. In South Carolina, diabetes accounts for $7 billion every year related to diabetes. And then unfortunately, I feel like 2013, I feel like that's forever ago, but that's the latest I could find statistics wise, that about 30,000 people are newly diagnosed every year. So that's kind of scary. Death rates, I hate to go over it, but it's important. About 1,200 deaths are associated with diabetes as an underlying cause. And with diabetes, the potential of years lost on your life would be about 4 years. So common coexisting conditions with diabetes, and there we go again with hypertension as the most common coexisting condition at 62.6%. Then we have what's called dyslipidemia, which is elevated cholesterol levels. That's next, 55.6%. Then we have heart disease, obesity, some hypothyroidism, cardiac dysrhythmias, so that's abnormal heart rhythm, and some heart failure. All right, so we're going to kind of move on a little bit to complications. Let me get a sip real quick. Okay, so hypertension, which is high blood pressure, is a major risk factor for what's called atherosclerotic cardiovascular disease and microvascular complications, okay? So atherosclerotic cardiovascular disease, what is that? Okay, that's considered what's called acute coronary syndrome, or myocardial infarction, which would be heart attack, angina or chest pain. If anyone has ever had what's called a TIA, which is a transient ischemic attack, which is basically a reversible stroke-like symptoms, or peripheral arterial disease, which is a decreased circulation to your peripheral extremities, that is thought to be due to atherosclerosis, which could be extra plaques. This is the leading cause of morbidity and mortality for individuals with diabetes, and the largest contributor to direct and indirect costs of diabetes. And 65% of deaths in people who have a diagnosis of diabetes are due to either coronary artery disease or cerebrovascular events, which would be a stroke. Then just going over the atherosclerotic cardiovascular disease again. People with diabetes have a 2 to 3 times the risk of having a stroke, heart attack, or sudden death compared to people without diabetes. This is why we're very big on trying to control your blood pressure, your blood sugar, and your cholesterol. So I figured we'd talk about microvascular complications. There's a lot of different little complications that can come with high blood pressure and diabetes, but these are the big ones, which would include eye disease, nephropathy, which is kidney disease, and neuropathy, which is nerve damage. So with microvascular complications, we talk about the eye disease, okay? Diabetes is the leading cause of adult blindness in adults 20 to 74 in the United States. People with diabetes are more at risk of development for glaucoma and cataracts early on in life. And poorly managed diabetes over time can cause what's called diabetic retinopathy. So when you go to the doctor, we recommend that you have a dilated eye exam. Okay, these are the screening recommendations. If you are a type 2 diabetic, we recommend that you get a dilated eye exam at diagnosis, and then every 1 to 2 years, depending on what the ophthalmologist recommends. And then if you are a woman who is pregnant or planning to get pregnant, we recommend doing a dilated eye exam in the first trimester and after you have delivered the baby. So when we talk about diabetic retinopathy or retinopathy, what is the retina? So the retina is the nerve layer in the eye that sends the information back through our optic nerve for interpretation by the brain. So it's basically sending the information about what am I looking at. Diabetic retinopathy is the most severe form of diabetic eye disease. It occurs when there's damage to the blood vessels that nourish and supply oxygen to the retina. The major causes of this would be elevated blood sugar levels, and then again, we go back to elevated blood pressure. Diabetic retinopathy is often detected within 5 years of onset of the diagnosis of diabetes. And about 21% of people with diabetes already have some form of retinopathy at the time of the diagnosis of diabetes. So sometimes we'll have people that came from the eye doctor and said, hey, my ophthalmologist said that my eye exam was abnormal and wanted me to get checked for diabetes. So sometimes that's how we'll end up finding somebody with that diagnosis. Risk factors for diabetic retinopathy would be the duration of diabetes. So the longer that a person has diabetes, the increase in risk for developing diabetic retinopathy. Your age at diagnosis, again, that's probably because it's taken a few years for you to develop the actual diagnosis of diabetes, but there was still dysfunction going on in your body for about 5 to 10 years. Glycemic control, so if your blood sugar is not under good control, that increases your risk of the complications. High blood pressure, smoking, both of those can decrease the oxygen or the nourishment to our eyes. Proteinuria, which is when you're spilling out protein into your urine. So sometimes we usually check your urine for microalbumin is what it's called, about every year, and kidney disease. Okay, so with diabetic retinopathy, there are two different types. There's proliferative, which is where new blood vessels are forming in the eye, and non-proliferative, where they're just dilated. The little capillaries, which are like the smallest little blood vessels, are becoming dilated, and they're leaking out little blood cells into the retina. Okay, the most severe seem to be the proliferative, because what's happening is your body is trying to compensate for the decreased circulation to your eyes and other parts of your body. So how it does that is it tries to create more vessels to get more oxygen or more nourishment to those areas. But then that ends up causing visual loss due to the little hemorrhages and then potential retinal detachment. So I just put in here the treatment for high-risk proliferative or severe non-proliferative, which are two different sort of ophthalmology treatment options, which is the pan-retinal laser photocoagulation, that's a big sentence, and intravitreous injections. But most commonly what we'll see in primary care would be an ACE inhibitor or an ARB, which would be like your lisinopril or a losartan, and obviously trying to manage your blood sugar and get it under good control. Okay, so switching gears a little bit to the kidney disease. Okay, so what do the kidneys do? We have two kidneys. They're in the back of the abdomen. Okay, the function of the kidneys is to remove water, urea, and waste. So it's a big filter. Maintain our blood volume, the acid-base balance and electrolytes. It regulates our blood pressure. It's a big part of regulating our blood pressure. And synthesizes erythropoietin, which is responsible for the red blood cells. And it maintains our calcium and phosphorus levels and activates vitamin D. So it does a lot. In the kidneys, we have millions of tiny blood vessels, which are the capillaries, and they have small holes that kind of act as a filter. So it's almost like a coffee filter, I would say. And blood flows through those little vessels, and the waste products get kind of thrown out and move through the holes and become part of our urine. When we have dysfunction, which I'll talk about soon, we'll have issues with our kidney disease. So I just want to talk about risk factors real quick. So if you look at the two biggest risk factors would be hypertension and diabetes. And then we have smoking, cardiovascular disease, our family history, if we're overweight, and if we're over 60. With diabetic nephropathy, which is diabetic kidney disease, that accounts for 20 to 40% of people with diabetes have diabetic nephropathy. Typically develops within 10 years of type 1 diabetes diagnosis, but may be present at the time of type 2 diabetes diagnosis. So what's happening in there? The elevated blood sugar, it's almost like a toxin at a certain level. So that our body wants to get rid of the toxins. So it's making the kidneys work harder. So the elevated blood sugar is increasing the workload of the kidneys. So over time, everything can kind of break down, and everything that we have in life can kind of break down if it's working too hard. So this is going to cause the filters to start leaking small amounts of protein, and that's what we call microalbuminuria. The increased work of the kidneys causes the filtering to decrease, have decreased capabilities, and waste products start to build up in the blood instead of being excreted in our urine. So the chronic kidney disease, over time, our kidneys can start to burn out, and it can progress to what's called end-stage renal disease. And those patients that have end-stage renal disease will require dialysis, which is where they go to those dialysis centers a couple times a week, or some people do have them in their house and do peritoneal dialysis to filter out the waste products, or they'll need a kidney transplant. And diabetic kidney disease is a leading cause of end-stage renal disease in the United States. These are our screening recommendations. So we usually do a glomerular filtration rate when we're checking your what's called a complete metabolic panel with your blood work a couple times a year. And then we do what's called an albumin creatinine ratio, that would be in your urine. We usually do that at the diagnosis of type 2 diabetes, and then after 5 years of type 1 diabetic diagnosis. How we diagnose diabetic kidney disease would be a glomerular filtration rate of less than 60 milliliters per minute. So that's how well our kidneys are filtering out wastes. And then persistent albuminuria that we would see on your urine tests that we usually do a confirmatory test 3 to 6 months after the initial to confirm the diagnosis. So how do we treat diabetic kidney disease? Okay, the big thing is treating the high blood pressure. Okay, so we have different targets. If we have the atherosclerotic cardiovascular disease, or as providers, we can calculate a 10-year cardiovascular risk. So that is a risk assessment of the potential for you to have a cardiovascular event, whether it be like a heart attack or stroke. So if that risk calculation is greater than or equal to 15%, our goal for your blood pressure would be 130/80 or less. Now, with pregnancy, if you have high blood pressure and diabetes, we want that a little bit lower. So that would be 120 to 160, depending on the age and comorbid conditions, over 80 to 105. Usually if you're an older individual, maybe like 65 or older, sometimes we'll have a little bit higher of a target, because we don't want to potentially make your blood pressure too low, and then we don't want people falling and breaking a hip. The other treatment besides medications and treating your blood pressure, again, would be the dialysis or a transplant. Okay, bringing it back around. Okay, so how do we prevent complications from basically both blood pressure and diabetes? Okay, if we get our blood pressure to target, which for most people with diabetes, our goal would be less than 130/80. That's been shown to decrease our risk of the microvascular complications and the macrovascular complications. So those would be the eye disease, the kidney disease, nerve disease, by about 24%. And this reduces the risk of you having atherosclerotic cardiovascular disease, heart failure, and protein spilled into your urine, if we can get your blood pressure under control. These are just the guidelines that we follow, the American Diabetes Association, and they also got together with the Cardiology Association and decided that these are our goals. For most patients with diabetes and high blood pressure, we want to treat it to less than 140 or less than the diastolic less than 90. But if you do not have many comorbid conditions or a younger individual, our blood pressure goals may be a little bit lower. Like I said, the less than 130/80. These are mostly our goals for your blood sugar for type 2 diabetes. For non-pregnant adults, the preprandial, which is before your meals, we would like your blood sugar to be between 80 and 130. And then 1 to 2 hours after your meals, our goal is to be less than 180. So if you're checking your blood sugar, you'll know that if you're in a good target or not. The A1C, which is that average blood sugar over the previous 3 months. Most people, our target is less than 7%. If you're younger, we would love it if we could get less than 6.5%, if we could get that low without having any potential side effects or low blood sugars from that, and less than 8% with a history of low blood sugar events, if you're older and have a limited life expectancy, or with long-standing diabetes and some vascular or cardiovascular complications. Our goal for you might be a little bit higher. With pregnancy, we really want very strict glucose control. So the fasting, which would be for the first meal, we would like it less than 95. And then 1 to 2 hours after a meal, we'd like it less than 140 or less than 120. And our A1C goal, normal, I forgot to say that. The A1C normal is less than 5.7%. And with pre-diabetes, what we call that is an A1C from 5.7% all the way up to 6.4%. Slide stop, okay. Other ways to prevent complications, okay? So a lot of the treatment for both diabetes and high blood pressure is going to be lifestyle modifications, okay? So weight loss if you are overweight or obese, which I usually go, if I'm working with somebody, I try and get our initial goal of about 5 to 8% of your body weight if we have that much to lose, because that's been shown to have positive benefits and decrease your risk of having a heart attack or stroke if we can get some weight off. With our diet, we'd like to watch our salt intake. The recommendations are less than 2,300 milligrams of salt a day. You'd be surprised at some of the foods that don't taste salty. If you look at the nutrition label, some of them are packed with salt. That causes, again, the water retention in our body, so it kind of swells, and our blood pressure will go up. And we might see some swelling in our legs and such like that. We would like to increase your fruit and non-starchy vegetable intake. The recommendations are 8 to 10 servings per day. And then kind of monitoring our alcohol intake. So men unfortunately get a little bit more, no more than 2 servings a day. And women would be no more than 1 serving a day. Increasing our physical activity. So the goal per week is 150 minutes of moderate intensity exercise per week. So that's actually kind of difficult to get to, at least if you haven't been very active before. So usually we try to get you to a target heart rate, which is based on your age and depending on medications that you're taking. So it's actually 150 minutes of exercise at a target heart rate. So someone will say, oh, I've been working out for 3 hours a day, but how many minutes out of that time were you actually at a target heart rate where you might be burning calories and fat? And obviously, if we're smoking, if we could quit smoking, that would be a great benefit to both diabetes and high blood pressure to prevent complications. What questions do we have? I feel like I talked really fast, so let me know, what are our questions?
Did you mention anything about neuropathy?
I did not. But neuropathy, do you have a specific question about it?
No, I thought it was in one of the lists, but maybe not.
It is a complication. So neuropathy would be the nerve damage. Again, from chronic diabetes or uncontrolled diabetes, you do have damage to the nerves, which cause the numbness and tingling that can develop in our feet and our hands. So that can be helped if we can really have a strict blood sugar control. And then usually once a year, your provider, or if you go to a podiatrist, usually does what's called a monofilament test, where we check your sensation to make sure if you step on a nail, you're going to know it. And usually we'll have individuals try to look at your feet every day, just so if you have cuts or anything, you'll be more likely to have potential for infection in our feet. And that causes infection and then leads to amputations if you can't feel it. And then you have decreased wound healing with your blood sugar being up.
Thank you.
What else?
I have a question. Oh,
Go ahead.
hello? Okay, I have a question about my blood sugar. It can be like 149 before I go to bed and I take my medication. And when I wake up, it's like just 10 points down, like the 149. I take insulin and I take pill at night.
So when we're looking at your, go ahead.
No, you go ahead. I'm good.
So when we're checking your blood sugar in the morning, that would be considered fasting, right? So what we can see is the liver is producing the sugar when it doesn't need to. So what's usually happening is if we're not eating, our body wants to maintain our blood sugar at a certain level. So usually it's between 70 and 100 is normal. So if we're not eating to put those calories in, our liver will break down fat and turn it into sugar for our brain to use. So part of the dysfunction with diabetes is it's breaking down the fat or producing extra sugar in your liver when it doesn't need to. And usually we'll see that in the morning blood sugars will be elevated because that's not, your blood sugar being elevated is not due to anything that you ate, it's due to what your liver is doing.
Oh.
So certain medications such as metformin or Actos help with our insulin sensitivity, and the metformin will decrease the liver's production of glucose. So that helps with our fasting blood sugars.
Okay. Well, the doctor took me off of metformin because it was messing with my kidneys. So.
Yes, at a certain point, if we are progressing and your kidneys are worsening, there is a max dose or recommendations for when we should pull you off of it. But there's about 8 things that contribute to diabetes. So that's just 1 or 2 things that are contributing that's also treated with the metformin. So you have other things that are treating your blood sugar.
Okay. Would pain increase your blood sugar?
Potentially, yeah.
Okay. Okay, thank you.
Meredith, I have a question. You mentioned about the sodium intake around 2,300 milligrams. Is that right?
Yes.
So now for African Americans, should our intake be less than that?
So usually what I'll tell individuals is that I like less than 2,000 milligrams. And if we're trying to be very tight, I would go between 1,500 and 2,000 milligrams or less. I don't think there's any actual recommendations as far as different ethnicities, but I usually like to go a little bit lower with sodium intake.
Okay, thank you.
What else?
I don't really have a question, but I have a comment. I've been on metformin for about 3 years. I mean, no, 5 years. And my last blood work showed that my B12 was very low. And I just learned that metformin can deplete your B12. Nobody had ever mentioned that before. So I've been taking B12 shots every month and feel so much better.
Yes, it has been associated with, especially at higher doses of metformin, the potential for a B12 deficiency is there. So I think we're becoming a little bit more aware of that in the last few years to test for it if you are on high doses of metformin, and obviously give you supplementation so you feel better.
Yeah. Okay.
What else? I feel like I talked really fast.
Your presentation was excellent. You covered a lot of information.
I feel like it was very hard to try and whittle down. I think I could talk about this for hours. And then I didn't want to be, this is probably already overwhelming.
I've got one last question, Meredith. You mentioned about the high blood pressure when you were showing the map and how high the prevalence was in South Carolina.
Mhm.
And I noticed there were a few other southern states that were listed on the high end. Why do you think that blood pressure is so high in South Carolina and maybe even in the southern states? I'm
Diet.
surprised to see Georgia wasn't high, but we were.
Well, it's up there. So I'm back on the slide. So the South is called the stroke belt, right? So the Southern cooking, the fried foods, the fatty foods, salty foods, diet, and the lack of, I'd say, normal physical activity would definitely contribute to the increased prevalence of blood pressure. I wish I had one for the diabetes prevalence as well. It'd probably be about the same.
On how we cook our foods.
Yes, it's good, but it might not be good for your body. What else?
Can you hear me?
I can.
Okay. I had been this is Melody. I had been listening to Dr. Chong, I think that's his name, or something like that. And he talked about, that's on YouTube, but he was saying about how a lot of doctors just treat the symptoms of diabetes opposed to getting to the root cause of what's causing the diabetes. And a lot of our doctors want to give just medication to treat the symptoms. So why don't they go more to what the cause of the diabetes?
So there are about 8 things that contribute to diabetes, but there's only so many things that you can control. So you can control what you put in your mouth, so what food you're eating, how active you are, and if you have medications, how compliant are you with the medications. So actually the medications, there's a bunch of different classes of medications, and they all treat different dysfunctions that are going on in your body that you cannot, you wouldn't know were happening. Let's say, let's go with the kidneys, okay? The kidneys, to try and compensate if your blood sugar is high, the kidneys are trying to filter that out, thereby trying to excrete it or get rid of it in your urine, okay? So if we see somebody that is not a diabetic, or we're just diagnosing them and they have glucose in their urine, we know your blood sugar is probably around 180 or higher, okay? So that means that with diabetes, there is an increased reabsorption. So instead of letting it go into your urine, that would be normal, okay? It's reabsorbing it into your body, and thereby your blood sugar is high, okay? So if you do not have diabetes, usually you'll start pouring out blood sugar or sugar into your urine at about, I'd say like 160, 180, if you checked your blood sugar at that time. But with a person with that dysfunction, it's probably higher. So it might be like 200 or 220 before you start pouring glucose into your urine. So the dysfunction is you're reabsorbing it. So certain medications that they will give you, such as they're called what's called sodium glucose transport inhibitors, which would be like a Farxiga or a Jardiance. Those sort of medications allow more blood or more sugar to be released into your urine, thereby decreasing your blood sugar, if that makes sense. And then with,
Okay, well,
am I going too far into it?
well, no, I was interested with my medications of Janumet.
Okay, so your medication is working on the gut. Okay, so you've got 2 things. You've got metformin, which works on the liver. So the dysfunction with the liver is you have increased production of glucose by your liver. And then it's also treating your insulin resistance. So the insulin resistance is your body is pouring out insulin by the pancreas, okay? It's pouring out insulin, but your body is actually not utilizing that insulin to bring your blood sugar down. So the metformin part of the JANUMET is trying to decrease your liver's production of glucose, increase your body's sensitivity to insulin. And then the other part, the Januvia in the JANUMET, works on the gut. So it tries to inhibit what's called DPP4, which is a gut enzyme that either speeds up or slows down basically our metabolism, thereby making our blood sugar go up. So the Januvia part works on the gut with your food intake, and the metformin's working on the liver. Does that make sense?
Oh, well, I hear you explaining it.
So when we're giving medications, a lot of it, when I'm speaking to people, a lot of it is diet. Okay, so I'd say about 80 to 90% of treatment should be diet modification. So watching your carbohydrate intake, watching your salt intake, fat intake, and increasing your physical activity. But certain medications are targeting certain dysfunctions. And we also look at the other conditions that you may have. So if you have heart conditions or if you have kidney issues, we might pick a medication one over the other, depending on what we're trying to change. Like if we're worried about your morning blood sugars before you eat, we might choose a different medication. Unless we're worried about your blood sugars when you eat, we might choose something different. So there's a method to the madness. I know some people feel like we're just throwing medications at you, and I promise it is for a reason.
Well, is it true that a lot of the medications cause the dysfunction in the body as well, leading to the because I was told, well, at least one lady said she believed that the metformin is what caused her to have to go on dialysis.
I would say it would probably be uncontrolled diabetes. You know, our whole job is to weigh the risk versus benefits, right? So if we feel like treating your blood sugar with a certain medication or getting it to a certain level is more beneficial than the risk of not, where we learned today the risks of complications can include heart conditions, kidney disease, all those things. So the benefit of us trying to treat your diabetes or whatever with the medication to try and prevent the kidney disease would be higher than us just letting it go and your blood sugar be high and then you damage your kidneys anyway. Does that make sense?
Yeah. Okay.
Because we never want to do anything that's more risky. We always think about safety. So, you know, that's why we monitor your kidney function and electrolytes and all that. Because if something's trending down, so say your kidney function and your filtration rate, that GFR, say that is decreasing, we need to alter your medication doses, or we need to really hone in on, do we need better blood sugar control? Do we need better blood pressure control? What do we need to do? Because sometimes the disease, if you don't treat the disease, that might be worse than the medication that you're taking, you know? What else?
But metformin is relatively safe, isn't it? I mean, that's what I've been told. It's been around forever.
Yeah, so when they had that recall, because I know everybody was worried about that for a while, that was on an actual manufacturer with inactive ingredients that got contaminated within certain manufacturers' medications and metformin. But other than that, I mean, the metformin, yeah, it's been around for years. It's relatively safe, but of course, if your kidney function declines due to other issues, obviously we try to change the dose or discontinue. And that's really with any medication. If it has the risk of causing, or your kidneys are worsening and we need to alter the dose because your kidneys aren't filtering as well. We're thinking about all of your medications as potentially need to be changed as far as dosing or take you off completely. What else?
Well, that was an excellent presentation, Meredith. I do appreciate that. You did a fabulous job.
Thank you so much. It actually didn't go too badly with my Zoom and my first PowerPoint presentation on here.
That's right. You did a good job. You were far advanced than most of us.
Any other questions?
Yes, any last questions? All right, they're hearing none. I guess this will conclude our Zoom support group meeting for tonight. Remember, we are on a summer break for July and August, so we'll pick back up in September. I don't have a date yet in September, but the hope is that we will be doing an in-person meeting, preferably one of our dining out options. So be on the lookout for that. Sometime in August, I'll have that posted. If you need anything else in the meantime, feel free to either text me or send me an email. And other than that, I will talk to you good folks come September. Have a good night, everybody.
Thank you guys.